This is Craig Shimasaki. I'm CEO and President of Moleculera Labs, and I wanted to share with you a newly published study, an article titled Evaluation of the Cunningham Panel in Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infections, otherwise known as PANDAS, and Pediatric Acute-Onset Neuropsychiatric Syndrome, otherwise known as PANS, changes in antineuronal antibody titers, parallel changes in patient symptoms. The article is online and it's open access. It was a retrospective study that was conducted by scientists at Moleculera Labs along with a dozen practicing clinicians across the country. The full-length article will be in print on February 15th, 2020. But you can access it through open access online at the link listed there below. So by way of background, I want to share with you just briefly about the targets of the antineuronal antibodies in the Cunningham panel. There are 5 tests, and these 5 tests measure for autoantibody titers and a self-stimulatory activity. As you can see here, the majority of them are directed against pre- and post-synaptic neurons, in particular the dopamine D1 and D2 receptors and the lysoganglioside and tubulin, which is an intracellular protein. The 5th assay is a self-stimulatory assay, and that particular assay measures the activation of Calmodulin CaMKInase 2. And that's important because it upregulates the synthesis of dopamine, epinephrine, and norepinephrine in the cell. As you can see here, this represents the test results. And as you can see, the 5 different tests, dopamine D1, D2, lysoganglioside, tubulin, and Calmodulin CaMKInase, along with the antibody and the activity scores. The retrospective case study in which we examine the correlation of these antineural antibody changes in patients who had 2 tests, one before and after treatment, and had clinical documentation of treatment and also their symptoms before and after treatment. So we examined all the results that we had. There was approximately 2,000 patients at this point who had been tested. And we identified 206 patients who fell within that period of time and had 2 or more tests pre and post treatment. We ended up with 58 patients that did provide a written consent who were not in a study already, and patients who we were able to contact and be able to retrieve medical records, clinical data, and symptoms and treatment. We then categorized those 2 patient populations into Group 1 and Group 2. Group 1 were those patients who completely resolved their symptoms and they greatly or markedly improved. Group 2 was the patients who did not improve, and in fact, many of them actually, their symptoms worsened. So that included 58 total patients, and all of those patients were then analyzed. In this table, what you can see is the clusters of symptoms by frequency and percent of patients in Group 1 and Group 2, and all patients met the criteria for PANDAS and or PANS, which include the sudden onset of symptoms and including the characteristic different types of symptoms required in order to be diagnosed with PANDAS or PANS. We then examined within Group 1 and Group 2, of which there were 34 subjects in Group 1. Again, these were patients who did completely improve or resolve or improved significantly. Group 2 were those patients who did not improve or actually worsened. You can see the age range was similar. The mean age in years was approximately 12 years. The ratio of female to male was identical. And the mean time between the first and the second Cunningham panel test was approximately 66 and 68 weeks respectively. There were no statistical difference between group 1 and 2 in the age or gender distribution, as you can see, and there was no statistical difference between group 1 or group 2 in the time between tests. We then looked at a heat map of all the patients in group 1 who looking at their pretreatment results, and what you can see is that all patients within group 1 had at least one or more positive tests in their panel. The intensity of the red indicates the degree of elevation of these autoantibody assays. And post-treatment, what we found in group 1 patients who improved or resolved was there was this dramatic difference in their treatment or their results post-treatment. As you can see, the majority of them resolved to baseline, and many of them, if they didn't resolve to baseline, had reduced the number of tests positive or the intensity. When looking at just the number of positive tests per patient, you can see in blue, pre-treatment, significant difference in those patients, the number of positive tests post-treatment. When we looked at patients in group 2, those that did not improve or their symptoms actually worsened, what we identified is yes, indeed, those patients pre-treatment did have positive tests. However, there was a group that did not have positive tests but met the criteria for symptoms for PANDAS and PANS. However, on post-treatment results, we also see that not only many of them had positive tests, which we believe is a characteristic of the time lag in which these antibodies are generated, but we also see the significant difference or the increase in the number of positive tests in these patients. And when you look at that graphically, what you can see is patients pre-treatment in blue, the number of positive tests post-treatment in orange. So when you're looking at that graphically in patients in group 1, looking at those that had a number of positive tests, 18 having a positive D1, 6 had positive D2R, 20 had a positive anti-tubulin, 6 for lysoganglioside, 27 for CaMKINase, whereas post-testing only 2, 2, 5, 0, and 8 respectively. Contrast that to patients in group 2 who showed no improvement or actually worsened. What you can see in these tests that are in this results is the patient test actually had either more positives or equivalent positives. We then looked at the sensitivity and specificity of the Cunningham Panel results as far as symptoms correlating to positive test results. What we found was a sensitivity of 88%, specificity of 83%, and an overall accuracy of 86%. Graphically looking at these in dot plots, you can see that there is good separation between patients in group 1 and group 2. And when plotted on a receiver-operator characteristic curve or an ROC curve, you can see the area under the curve is 93.4%. We then looked at the data in another way. Irrespective of what was a positive or a negative, we looked at the degree or the magnitude of change in the results, and through a logistic regression, we took all 5 tests and assigned them a score and identified and measured them in a logistic regression analysis. In doing so, we found a very similar sensitivity and specificity, 88 and 92% respectively, with an overall accuracy of 90%. But when you look at the separation between the two groups, you can see much clearer separation. And this provides future value in the idea of the possibility of 5 different tests, each contributing to the results, but no one individual test by itself can contribute the benefit of all the results. And again, when you look at the receiver-operated characteristic curve, you can see that it has a similar area under the curve of 95.7%. When we look at the CaMKInase activity alone and compare that to group 1 versus group 2, what we find is that the mean score for CaMKInase actually is significantly and statistically different. Patients who in group 1 who improved or completely resolved, as you can see, had an average of about 150 CaMKInase activity. Positive is a threshold of 130. And what you can see here is that pre and post for group 2, there is no statistical difference between those patients. What this leads us to is some conclusions, is that patients may have differing underlying etiology for various types of clinical symptoms, for tics, OCD, eating disorders, anxiety, whereas we know that PANDAS and PANS is a clinical diagnosis, but it also includes many of those symptoms. And it's quite possible and is very likely that various symptoms like tics, OCD, eating disorders, and anxiety, portions of them can actually have an underlying autoimmune etiology, which we actually see with the results in the Cunningham panel. But this leads us to the potential conclusion, and has been identified in many other publications, is that clinical diagnoses, such as disorders as epilepsy, schizophrenia, ASD, ADD and ADHD, chronic depressive disorder, which are clinically diagnosed, a portion of each of those may have an underlying autoimmune etiology. And the benefit to this is that precision medicine would allow the differentiation of patients to be treated based upon the underlying etiology rather than be treated by the symptoms. And in fact, that is what we see in practical studies, is that patients, when identified and separated by the underlying etiology, respond better and more effectively to treatments that are directed against the underlying root cause. This is the basis of precision medicine in cancer therapy, and we believe that this is where autoimmune or underlying neuropsychiatric disorders will be headed, in which we can identify patients based upon an underlying etiology, treat the underlying etiology versus treating the symptoms. And at Molecular Labs, our mission is to help change how medicine is practiced for neuropsychiatric disorders. And we know that you are at the front line, and so we thank you for helping those suffering with disorder to gain hope and get well. I'd encourage you to download the article and at the Journal of Neuroimmunology. And if you have any questions, feel free to please contact us. We're here to help you. And that concludes this presentation.